Hello everyone. Today's the class topic of discussion is anemia. Myself, Dr. Rishi Agarwal. I am MBBS, MD Medicine, and currently doing DM Gastroenterology in the Bikaner. So first, when the patient of anemia come to our OPD, what the chief complaint of the patient will be there? So chief complaint of the patient will be easy fatigability, low mood, irritability, dizziness, generalized weakness, headache, or syncope. So then we will go for the general physical examination of that patient, and we will see for the pallor. What are the all the sites where we can see the pallor is lower palpable conjunctiva. Second thing is skin, that will be look pale. Then nail beds. At last we can see at the palms and soles. So they will look like a pill. So we will make a probable diagnosis of the anemia. So next investigation we prescribe is the CBC. So CBC, we first see the hemoglobin. If it is low, how much low we will discuss later. Then we'll call it anemia. So that's how we diagnose the case of anemia. At this time of point, we are not classifying the anemia. So we have diagnosed the patient with anemia. So in CBC, you have to see three things: the TLC, hemoglobin, and platelet. It is a single lineage defect or bilineage defect or triple lineage defect. Because if all the three lineages are affected, then it will be called the pancytopenia. Approach of that will be different. If the only any two lineages are affected, then it is called bicytopenia, of which approach will be different according to the lineage that is affected. Our main focus is on the hemoglobin. That is solely anemia. Other things we see in the CBC reports are MCV, MCH, and MCSC. According to that, we will classify the anemia. So this is the basic approach by which we are going to read the anemia. You have to first see the chief complaint of the patient. Then you will examine the patient for the pallor. Then you will prescribe the investigation CBC, in which you will see that it is a single lineage defect, bilineage defect, or trilineage defect. Is it pancytopenia, bicytopenia, or only anemia? Then we will see in the CBC other indices of the red cell mass, that is MCV, MCH, and MCSC. So this is the basic workup, basic thing in our anemia. So now we will go further. So this is approach to anemia. First, we will classify the anemia. It is the patient is anemic or not. So what is the WHO guidelines for the anemia? That is hemoglobin is less than 13 is the male, less than 12 in the female, and less than 11 in the pregnant female. These are the this is the cutoff value below which we will see it the anemia. Say it as anemia. Now we will go below. So what are the physiological regulation of red cell production? When there will be anemia, the marrow will be tried to compensate it by producing more and more red cell, because the production of the red cell mass is dependent on the erythropoietin. That will stimulate the bone marrow, that will increase the red cell mass, and that will increase the hemoglobin concentration. So what are the elements of erythropoiesis is, first is that there will be a EPO production. EPO production will be lead to increase the marrow activity, and EPO is produced by the kidney. Then we will see for the iron availability. Then we will see the proliferative capacity of the bone marrow. Then effective maturation of red cell mass. First thing, that is the stimulator, that is EPO, that will stimulate the bone marrow. And bone marrow have to have some raw materials like iron, folic acid, and other cell to proliferate. Then what is the proliferative capacity of the bone marrow? It is bone marrow is more acting or not acting. If there is more lysis in the peripheral blood film, so bone marrow have to work more. That is proliferative anemia. If bone marrow is not working well, that is also called the anemia or pancytopenia. Then bone marrow is working, but there is no effective maturation. Because of maturation required DNA, and DNA required iron and folic acid and vitamin B12. So these are the classical things by which we can diagnose the anemia. So what basic investigation which we need to classify the anemia? So only two investigations that will need, that are CBC, PBF, and retic count. Only three investigation which we need, that is CBC, PBF detail, and retic count. In CBC, we will see it is anemia or pancytopenia, and we will see the MCV of that patient. So first, then we will see for the retic count. So when there is anemia, so decrease hemoglobin, that will increase the proliferative capacity of the bone marrow. Bone marrow will produce more retic. So see, one patient is having hemoglobin of 14 and his retic count is 2. That is normal. If patient is hemoglobin is 8 and retic count is 2, that is abnormal. Because more the anemia, more should be the retic count. That will tell us the proliferative capacity of the bone marrow. जितना कम है उतना bone marrow को proliferate करना पड़ेगा to increase the bone marrow production. So we have to see the corrected reticulocyte count. Or lab will be give us the only reticulocyte count, but that reticulocyte count is appropriate to the level of the anemia. We have to see the corrected reticulocyte. That the formula is patient's hemoglobin but a standard hemoglobin into lab report of retic count. For example, if patient is having hemoglobin of, let's assume 7.5, and we take it as 8, and we consider standard hemoglobin as 12, and retic count is 3%. So what will be the corrected reticulocyte count? That will be 8 by 12 into 3. It is 2 by 3. That will be 2%. Okay. So this will be the corrected reticulocyte count. Now, corrected reticulocyte count will be further modified by the reticulocyte production index. Then what is the reticulocyte production index? Suppose the patient is having hemoglobin of 6. His bone marrow is proliferating. So bone marrow will proliferate more. It will release premature reticulocyte count. That will have more half-life than actual reticulocyte. So we have to correct reticulocyte count by reticulocyte production index will be corrected reticulocyte count but a shift factor. It depends upon the hematocrit. If hematocrit is 45, it will be 1. 35, it will be 1.5. 25, it will be 2. 15, it will be 2.5. Suppose patient is having hemoglobin of 8. Standard hemoglobin is 12. Retic count is 3. And his hematocrit is 25. So what will be the reticulocyte production index will be 8 by 12 into 3. That will be corrected reticulocyte count. That will be 2. And what is the reticulocyte production index is 2 beta, according to this, 2 is equal to 1. So RPI will be 1. So now we will go through the slides. Approach to anemia. First, we will see the reticulocyte production index. What is the reticulocyte production index? If it is more than 2.5, it will be have hemolytic anemia. That is hemorrhage. So in hemorrhage, there will be peripheral hemolysis of the blood cells. So there will be loss of hemoglobin. So bone marrow will proliferate more. When the bone marrow will proliferate more and it is have the proliferative capacity and it has the raw material, it will produce the more reticulocyte. So reticulocyte index will be more. So these are the causes of hemolysis, that is blood loss, intravascular hemolysis, that is PNH, metabolic defect like G6PD deficiency, membrane abnormality like hereditary spherocytosis, HB sickle cell anemia, immune restriction, that is autoimmune hemolytic anemia, or fragmented hemolysis, that is microcytic autoimmune hemolytic anemia, that is MAHA. When reticulocyte production index is less than 2.5, that signifies that there is a defect in the bone marrow. That bone marrow is not appropriately working according to the level of anemia. So what will be the next step? We will see the red cell morphology. If it is normocytic and normochromic, that is MCV is normal and MCHC will be normal. So if it is normocytic and normochromic, it will tell us by the MCV and also by the PVF detail. So reticulocyte and PVF detail. So if it is normocytic normochromic, that it signifies there is a defect in the production defect due to defective proliferative capacity of the bone marrow. So it will be classified as a hyperproliferative anemias. Hyperproliferation can be due to the marrow damage. If it is marrow is infiltrated by the malignant cell, if it there is myelofibrosis, there will be aplasia of the, that is aplastic anemia, or decreased stimulation renal disease. As I said that the erythropoietin that is released from the renal fibroblast will stimulate the kidney. So if there is decrease in erythropoietin, this will classify as a hypoproliferative anemia. On the other side, there will be microcytic or macrocytic. That is due to nuclear maturation defect. So maturation defect can be due to the nuclear defect or cytoplasmic defect. Cytoplasmic defect, that is microcytic hypochromic anemia. That is the most common type of anemia. Trick of this is Sita M. Sideroblastic anemia, iron deficiency anemia, thalassemia, and anemia of chronic disease. So these are the causes of cytoplasmic anemia. And what is the causes of nuclear defects? That is megaloblastic anemia. There will be cell size will be more. That is folate deficiency, vitamin B12 deficiency, any anti-folate drugs, or refractory anemia. So this is the algorithm of the classification of the anemia. So first we will see the CBC, it is a anemia or pancytopenia. Then we will see the reticulocyte production index, that marrow is working more or less. If marrow is working more, then cause of anemia is peripheral lysis. So we will see the further detail for these causes. If reticulocyte production index is less, it is a defect in the bone marrow. Bone marrow can have defect in proliferation or can have defect in maturation. Proliferation is there is bone marrow is not working. Something has invaded the bone marrow or something has stopped the bone marrow. These are the hyperproliferative anemia. Then we'll see the maturation defect. Maturation can be due to the cytoplasmic or nuclear defect. The causes of this. So these are the approach to the anemia. Then what other investigation we can do? So these are the clinical presentation. As I said, routine we can found it and during routine screening. One thing is that the acute blood loss causes the loss of whole blood volume. So there will be no decrease in the hemoglobin and hematocrit. It will decrease after the 48 hours of the blood loss. So we can suspect the level of hemolysis according to the symptoms. So if it is a mild, there will be no symptoms. 10 to 15% of blood loss patient will have hypotension and decreased organ perfusion. Or more than 30% of blood loss, there will be a postural hypertension and tachycardia. And after the 40% of whole blood loss, patient will have hypovolemic shock. So how we can classify the acute blood loss. Clinical presentation can be have intravascular hemolysis. Patient will have black color urine. That is the most important. Or patient will have acute back pain due to the acute hemolysis. In moderate anemia, patient will have fatigue, loss of stamina, breathlessness, tachycardia. One thing is that if patient is having the chronic anemia, he will be asymptomatic due to compensatory mechanism. That is, binding, the hemoglobin binding capacity will increase. There will be other factor that will make the patient asymptomatic. If the patient is having the acute anemia, there is acute blood loss or anything acute that is causing the anemia, patient will be more symptomatic. So these are the clinical presentation. What are the causes of anemia? Infection. Most common cause of anemia is in our India is nutritional anemia. That is iron and folic acid and vitamin B12 deficiency. Other causes are infection, rheumatoid arthritis, cancer, lymphoproliferative disorder. What are the things we will see in the history of the patient? That is, if the patient is having any other known case of disease that is causing anemia, like COPD, like CLD, like CKD, gastric ulceration, rheumatoid arthritis, renal failure, duration of symptom, any HB pathies, any treatment history, any medication for the pain, or any nutritional history. What are the points we will see in the examination? All the signs of malnourishment and pallor, jaundice, any bony tenderness, that will support the multiple myeloma as a cause of death. PET TK, that will signify patient is having also thrombocytopenia or platelet defect, any murmur or splenomegaly. Investigation I have described. What are the findings we can see in the peripheral blood film is cell size. What amount of hemoglobin does the cell contain? That is MCHC. Any abnormal type of cells, that is anisocytosis, different size of cell, poikilocytosis, different shape of the cells, polychromasia, containing the more chromatin, gives clue to specific. Like this, in the severe iron deficiency anemia, we will have the microcytic, the cells having low size, and hypochromic, having more pale than the normal cell. And they can have pencil cell, clue cells. These are the cells we can find in the severe iron deficiency anemia. These are the megaloblast or macrocytes. This is the teardrop cell, can seen in the myelofibrosis. This is the teardrop cell. This is a pencil cell. This is the nucleated RBCs. This is a microcytic hypochromic RBCs. These are macrocytes. So these are the Howell-Jody bodies that's seen in splenectomy patient. That is nucleated RBCs. If patient is having the nucleated RBCs, that defective RBC is not removed by the spleen. So this Howell-Jody bodies is seen in splenectomy. These are the RBC fragmentation that can seen in the microcytic microangiopathic hemolytic anemia. In this, that the vessels lumen is shrink. So when RBC passes from that passage, there will be shear and tear force in the RBCs, and RBC lysis will occur. That will cause the fragmented RBCs. In uremia, we can see the Burr cell, or in CLD, we can see the spur cell. Burr cell have regular and same size of spike. Spur cell have irregular spikes. Reticulocyte count I have explained how to calculate the corrected. There's the iron supplies and storage. What is the treatment of anemia? That will study in later. Then there is a bone marrow studies. When there is a hypoproliferative bone marrow, we have to see what is the cause of bone marrow defect. So we will go for the bone marrow aspiration and bone marrow biopsy, in which we see what is the myeloid to erythroid ratio. Is there is increase in the myeloid to erythroid ratio? Myeloid to erythroid ratio can cause due to the malignancy, that is leukemia, lymphoma. What are the kind of iron stain in the marrow? What are the cellulite in the bone marrow? Or what is the morphology in the bone marrow? So these are the reticulocyte production index and marrow ME ratio. Maturation defect, that is due to the folate or vitamin B12 deficiency. Any drug that is methotrexate, that is decrease the folate and vitamin B12 action and causing its deficiency. Myelodysplasia, bone marrow is dysplastic, containing the dysplastic cell, that is dysmorphic cell, that will occupy the bone marrow space and causes the anemia. Alcohol causes macrocytosis with variable anemia due to folate deficiency. What are the causes of cytoplasmic maturation disorder? Is SITA M. That is trick is SITA, SITA. Anemia of chronic disease, thalassemia, iron deficiency anemia, and sideroblastic anemia. So these are the causes of cytoplasmic maturation defect. So this is the all about the anemia. The basic concept is you have to see the first, you have to attend the patient in the clinic. You suspect by the symptoms, then you go for the examination to see the pallor at the different sites. Then you will see the advise the CBC. You will see it is a anemia, bicytopenia or pancytopenia. When it is solely anemia, you have to see the reticulocyte production index. That if the reticulocyte production index is more than 2.5, it will be peripheral hemolysis, that will from the peripheral lysis of the RBCs in the blood or any organ. If it is reticulocyte production is less than 2.5, it is defect in the bone marrow. Bone marrow can have two types of defect. Either the bone marrow is not functioning, that is hyperproliferative anemia, that will have normocytic and normochromic cells in the peripheral blood film. If patient bone marrow is working, but there will be a maturation defect, then the patient will have in the microcytic or macrocytic cells in the PBF. So maturation defect can be due to the cytoplasmic defect or nuclear defect. So this how we will approach the patient of anemia. And if we have leading point that patient is having any lymphadenopathy or any other things, we will go further according to that. So this is the class on anemia I want to present.